Can I look at my QM test from 2 years ago?
You know, let's go dig it out. If you really want to see it.
So Max, I've decided that if I was a zombie, I would eat your brains first.
What a compliment!
You know, I can take that a couple of different ways.
It's a compliment.
It is, okay.
And then I think Mason's would be fun because it'd be with his hair, it'd be kind of like a brain spaghetti.
To make it interesting, right?
Yeah.
So is like Mason like the warm Max the main course?
No, Max is first.
That's right.
I gotta get those.
But if you're a zombie, how much do you care about intelligence anyway?
You need all that you can get.
Protein.
You're short on it if you're a zombie. Right?
Exactly.
Of course, I'm not sure you care either, but you know, I'm hardly a zombie expert. Since I only recently learned,
right?
So I only recently learned who Jon Snow really is, so you can't ask me about zombies.
Mike, is it okay I go on at the same time?
Oh, sure. Okay, as usual, I'll get started on this, then we can take a break at about 4. As usual, these are some really good references, and these are the ones that I use to write the lecture, just so if you want to go look up anything. This one is extremely unreadable. This one's probably next to that is the least unreadable. The Kelsey, Bordas, Freiwalds, and Checkaway, Pearson, Crawford, Brown, those are probably the most readable of all 6 of them. The basic types of studies, of inferential studies in epidemiology, are case control and cohort. I'm going to build on the differentiation between the two as the lecture progresses. But I want to start out with 2 very important distinctions between them. Look at the first one. The first one for cohort, the first one for case control, is based on how subjects are chosen. It's an extremely important difference between the two, or way to differentiate between the two. A cohort, you choose your subjects based on exposure. And you'll get really tired of seeing this 2x2, but this 2x2 contingency table is the most basic version of each one of these. Exposed and non-exposed is the distinction between the two. The line over it means not, right? It's a negation when you put a line over something like that. And here is cases and controls. Okay? The cohort study, you choose based on whether they're exposed or not exposed. And then you, as the name implies, cohort, you follow them through time, depending on the latency of the condition that you're looking for. You might need to follow them months, days, months, years, depending on what it is. Some forms of cancer would be years. Something like developing a headache because of exposure to a chemical probably is hours. Okay? But nobody at the beginning has the condition, but you divide them into exposed and non-exposed. So that means that there are 2 types for a cohort: retrospective and prospective. As the name implies, you look to the past or you look to the future. Retrospective is difficult to do because it requires extremely good data gathering. Okay, so what I do is I have this data set that I've been collecting, and I go to a point in the past and I say, all right, here are all the people that have been exposed, here are all the people who have not been exposed. Then I come up to look up at the present, and I say, of those people, how many have developed the condition and how many haven't? Without excellent data, you cannot do this. I've only been, in my experience, at one place that has good enough data to do this, and that was at Ford. They actually keep data that is excellent. It's a huge database. And now it's not, actually now it's not so much. That was 15 years ago. And then they had these terabyte drives that they were keeping things on. Now you stick a terabyte drive in your back pocket. Then you didn't do that. But it was 85,000 employees worldwide, and there was, and by now they have 24 years worth of data, so you can imagine. So prospective, retrospective is hard to do. Prospective, not so hard. You have people who are exposed, people who are not exposed, and then you interview them periodically over the next day, weeks, months, years, depending on what the latency of the condition is. But what's important with the cohort is that none of them have the condition to begin with. All you know about them is whether they're exposed or not exposed to your risk factor. Case control, on the other hand, is just the opposite. You take database and you divide people up into whether they have the condition or not, and then after the fact decide what the exposure is. Were they exposed or were they not exposed? It has to be, it's cross-sectional, strictly speaking, but it's kind of retrospective because you must know that the condition preceded, that the exposure preceded the condition. Sorry. You must know that, or else you can't establish causal relationship. Okay? So it's, in a sense, it's retrospective, but your data are really cross-sectional because you're just looking at it right now. Okay? So for the case control, you choose people based on whether they are cases or controls, whether they have the condition or not. And cases are people, I probably should have said this, cases are people who have the condition, and controls are people who do not have the condition. Yeah, probably important to say, sorry about that. So you choose them based on the condition, and then reconstruct their exposure. And it's cross-sectional, kind of retrospective in some ways. These are the two basic types of studies. They can be, it can be extremely simple, putting it into a 2x2 table like this, where you just have one exposure, and you're looking for whether or not the condition is developed. Or you can have a lot of exposures. If you do the simple 2x2, it's just arithmetic. If you do the more complex version of it, for case control, you use logistic regression, which we will be talking about after the next exam. And for cohort, you use a Cox regression, which we won't be talking about. We just don't have time to get into it in class. But I will talk about logistic because it's very commonly used. So that's the basic distinction between cohort and case controls. Like I said, I probably should have showed you this first. I keep switching these two back and forth. I never know which one to talk about first. But this is your standard 2x2 table. This is and you have to remember that the exposure is in the rows, the condition is in the columns. It's just that's just a convention. And then you have marginal and grand total. Cases are those with the disease, controls are those subjects without the disease, exposed, they have been exposed to a risk factor, not exposed, they have not been exposed to a risk factor. So those are four terms you need to get used to using. Cases, controls, exposed, not exposed. So let's talk in a little bit more detail about case control studies. And I think this is a nice illustration because with a case control study, you have your group, your sample population, and you test them for whether or not they have the disease. Or you look through the database to see whether or not they have the disease, however you're determining that. And then you classify them as cases or controls. And then you determine, either by test or by looking at a database, whether or not they were exposed to the risk factor. So we end up with our four cells here. If they were cases and the risk factor was present, that's right here. This is cases with the exposure. If they are cases with risk factor absent, That means that they are cases with no exposure. Then over into the second branch here, if they are controls with the risk factor present, that's right here. Risk factor, exposure, and their controls. They don't have the condition. And then the one remaining is controls who weren't exposed, which is the last. Risk factor absent and their control group. So we choose the subjects based on whether they do or do not have the condition of interest. And this is really appropriate if we have rare conditions. Because if a condition is rare, and you try to do a cohort study, you could end up waiting a very, very long time for it to develop. So sometimes the nature of the condition or the latency of the condition will force you into a case control type of a study format. And then retrospectively here, that's the retrospective part, we reconstruct whether or not they were exposed to the risk factor or not. We don't want to bias it, so for the cases, the people with it, we don't want to have bias with respect to the exposure. That means that you don't want to have your cases, a whole bunch of them in the exposure and very few in the non-exposure. You want to make sure that you have a valid, full sample so that you don't bias it towards the exposure and therefore making it look like it's a higher risk factor than it is. And also, since we're classifying them versus cases versus controls, we have to be sure that we are classifying the cases appropriately. In other words, have a case definition which you use consistently for every person, every subject that you examine. So, if you're using carpal tunnel syndrome and you're using Phelan's test, consistently use the results of Phelan's test. Don't use Phelan's test for some and a nerve conduction velocity for others. Okay? All of them should be tested by the same criterion. Okay? Okay. This is where it's good. Right? I already talked about rare conditions and exposures that are very common. It's not very expensive because usually we're looking at databases very frequently. I can take a database, divide them up, and I'm good to go. Because it's cross-sectional. And also, it's very commonly used in occupational settings because when people come to the plant medical, they're usually seeking help for some problem. It gives you, and so you can easily classify everybody in the plant. If they haven't come and looked for, and asked for a wrist splint or something like that, you can probably, for the most part, guess that they don't have the condition. And as I'll show you later, exposure is an estimate. What that means is that we are, to a large extent, making the assumption that the exposure occurred before the condition developed. Since we're looking retrospectively, we can't always say that. And that's why we get into so many problems with occupational, because many employers, and to a certain extent rightly, I think that they overplay this hand, but to a certain extent they're correct, is that they will say, this condition preceded the exposure, or another one more commonly is that the condition is from an extracurricular activity that's outside of work. Right? So somebody has repetitive motion problem, well, do they knit, do they tie flies, do they do repetitive activities as hobbies outside of work? Right? Well, you usually can't ask that. And like I said, it's not that it's not a legitimate problem, but I think often it's overplayed in a lot of cases. But that is a problem with case control. So we don't know. We're making the assumption that the exposure preceded the condition. And exposure estimates themselves. We're going to be talking, the next topic is going to be error. Now, one of the biggest things biggest errors is bias. And one of the types of biases that we'll be talking about is recall. People are notorious for not being able to recall things, even if they're trying accurately. Okay? I mean, isn't that one of the first things that Professor Waldock teaches you? Is don't rely on witnesses, because they'll probably be wrong, or they'll all be different. And that's exactly what, that's what recall bias is. We're not very good at remembering things. We introduce bias, we introduce what we thought we saw, or what we think we remember. So, go ahead.
Last slide. So when we say the exposure is an estimate, you mean the conclusion you deduce from this type of study is very subjective? Is that what that means?
No, I have actually a mathematical definition that I'm going to give you.
Okay.
And that's what I mean by that. What you're referring to is kind of the recall bias.
Okay.
That's the part that is has a subjective component to it.
Okay.
Okay, now let's switch to cohort again. I know I'm switching back and forth, but it's important to compare and contrast these two types. Now, remember with cohort, we choose a bunch of subjects, none of whom have this condition. We test them to make sure that they're all free of the condition. And then they either naturally, based on their work, or are assigned to the risk factor and not the risk factor, exposure or non-exposure. Okay. So let's take a look at the diagram first. Okay, so they have, if they test them for the risk factor, somebody has it. Let's say we're trying carpal tunnel syndrome, just as an example, since I like that one. If somebody is tested for positive for carpal tunnel syndrome, they're excluded from the study. That's the non-participants, because we want people who are free of the condition. And then they assign them to exposure, risk factor present, or non-exposure, risk factor absent. Another type of error, because this is over time, even if it's hours, okay, even if we're talking about hours, people get bored. They walk out. You can't chain them to the desk and make them stay there until the study's finished. And if this is years, you're bound to lose a very, very large percentage of your subjects. That's the type of error called loss of follow-on. Okay? So you're going to lose a certain amount of people. Then they have some exposure time. It's again, exposure time depends on the latency of the disease. Okay? Like I used an example when they did this actually in a public health school. They wanted to see whether or not people who pumped their own gasoline were more likely to develop headaches. Okay? And it was at Rutgers, so it was in New Jersey, where it's illegal to pump your own gasoline, believe it or not. Every gas station, at least when I lived there, had to be manned by a person who was a professional gas pumper. Okay? So nobody pumped their own gasoline. So they wanted to look at it. So they said, okay, we're going to take a bunch of people and have them pump their own gasoline, another bunch of people have them not pump their own gasoline, and after a couple of days, see who develops headaches. There were other conditions they were looking at as well. So this was a few days. But it's something like some types of cancer, that could be decades between here and here, because there is, has anybody heard of the Framingham Heart Study by any chance? Framingham, Massachusetts, it's west of Boston. They have had a heart study that's, I want to say the 60s is when it started. It's still ongoing. It's the one that established a relationship between things like diet and exercise and coronary heart disease. That's the Framingham Heart Study is the reason that we know those relationships exist. It's been going on for 60 years now. Now that's a longitudinal study, and they are definitely going to have lost to follow-up. But you can see, to get something like heart disease, you have to have decades-long studies in order to establish any kind of relationship. So anyway, then after your exposure, whatever time that is, you test to see whether they are cases of controls. So you test this is exposure, outcome present. That's right here. Cases who have been exposed. Then you have exposure, outcome not present. So that's right here. It's exposed who are controls, who don't have the condition. And then likewise, risk factor is absent. Those are the non-exposed, outcome present, outcome absent. So this is risk factor is absent, outcome present, outcome absent. In each one of these, the bottom row is has four cells, okay, four possible outcome combinations. And that's what this 2x2 table is supposed to represent. Okay, anything else that I want to talk about, okay? You have to make sure that the study population, because you're never going to study everybody, you have to make sure that it's representative. Okay? And later, and next week and the week afterwards, we're going to get to what's called matching. Matching for gender, ethnicity, age. Because you don't want to have, all male and all, in one group, all female in the other group, or all one ethnicity in one group and all another ethnicity in another exposure group. You want to make sure that everybody is represented in both the exposed and the non-exposed here. Okay. You don't have that choice so much with with the case control study, because you're selecting them based on condition. With this, you can't, because you're selecting them based on exposure. So you should be able to make sure that you have a representational sample that represents your population at large. Yes?
This may be off topic, but could Doroscope or the alpha statistic ever be used with a table like that?
No, because that's a table of agreement. This isn't a table of association. There's a difference between the two.
So, on that schematic diagram there, can you please explain the loss to follow-up again, please?
Sure. Regardless of how long you have to wait in order to interview your subjects, people are going to leave the study. And the longer it is, the more likely they are to fall off the map. I worked at Liberty Mutual for a while. That's how I knew about the Framingham Heart Study, because we worked with them. And we did longitudinal studies. It was very, very difficult to interview people after just a couple of weeks. They changed their numbers. It was amazing how they could drop off the face of the earth if they wanted to. So that's what loss to follow-up is. And it happens all the time. And no matter how much you pay them, they will just disappear. It's a known factor. Okay. Well, we talked about that. Document the cases as they occur. That's what you have to interview fairly regularly. Not only to keep people interested, to minimize this, it's going to happen, but you can minimize it by contacting them every week. Okay? They've signed up for it, they're getting paid for it, so contact them frequently. And they'll still disappear, but that way you can tell how long it takes cases to develop. Because when you're doing like a Cox regression, for instance, it's important to know how long the exposure was before the cases occurred, not just count them. And make sure that you complete follow-up. For the exposure, again, this is like your case definition for exposure. Make sure that you measure it with the same equipment. Make sure that the equipment is calibrated, whatever it is. Make sure that your exposure is comparable. And make sure that the exposed and non-exposed populations are comparable to each other as well. Is everybody getting the sense of the difference between the case control and the cohort approaches? Is it clear so far? Okay. All right. So for cohort studies, then, we would want, since for case control it's uncommon conditions and common exposures. Here, cohort is the opposite. Rare exposures in relatively common conditions, because remember the condition, we're waiting for it to show up. And if it's rare, it probably won't show up no matter how long we wait. And then everybody will drop out of the study and we'll never find out. So your condition should be common with cohort studies so that it actually occurs during the course of the study. Problem with it, especially if it's a decade, you can imagine how expensive it is. Because not only do you have to pay staff to interview and do follow-up on all your subjects, you also have to pay the subjects to keep them interested. Because if they're not being paid or compensated in some way, they are going to lose interest very quickly. So it's expensive to do. You have to have a much larger sample size than you do for a case control analysis. Obviously, it's time consuming because you've got to keep calling people on a weekly basis, monthly basis, whatever. It is, and you have that lost follow-up problem, which is pervasive. And so cohort experiments are hard to do, but they are considered more rigorous in many ways. Yeah.
So I know this might be a very crazy question here, but can you please give an example of, from your experience, right, of rare conditions and rare exposures and common conditions? At least that would really help kind of break that up.
A rare exposure would be something like exposure to a nuclear bomb blast.
Okay.
I mean, that doesn't happen very often because very few set off.
Okay.
A rare condition would be something like anything that has a very low prevalence. There are some forms of cancer that are extremely rare, for instance. Developing some autoimmune conditions are very low prevalence in the population. I can't think of anything musculoskeletal. That's what, because musculoskeletal and the things that we look at in occupational settings tend to not be rare conditions. Nor is exposure necessarily rare, but they're not rare conditions, which means that we could do a cohort on them because they develop very quickly. So those tend to not be rare conditions, but when we talk about rare conditions, it's usually things that are very low prevalence in the population, like autoimmune, some cancers, that sort of thing.
Okay.
Does that help?
Yes, sir. Thank you.
Let's see. Okay. Let me do the next two slides and then let's take a break. The time orientation. I already alluded to the time orientation and cohort study. If right now I assemble my study group and then I interview them or contact them regularly over the next X amount of time, hours, days, months, years, decades, whatever is required, that's a prospective because I'm starting now and moving into the future. Okay, so that's a prospective study. And that's called a prospective cohort. And again, the retrospective cohort, I already talked about it, but I'll mention again, I need an extremely good database. Okay, so that I can go back into the past, choose a bunch of people in the database none of whom have the condition of interest, and then look at them now. Okay? How many of those people who didn't have the condition 5 years ago have it now? Now, this is a lot cheaper because you're using data, but there's very few places that have that level of detail in the data. Like I said, I've seen one so far. So the outcome occurred in the past, everything was in the past, and I'm just looking at the data and reconstructing it. Outcome occurs in the future, assess exposure, the time the study begins. Here I have to assess the status at some point, days, months, years ago. And then I record the condition as it occurs. I interview people. Here I have to reconstruct that incidence data. I have to look at my records periodically, every month, whatever makes sense for the latency of our disease, and follow it up to the present. There's an interesting combination of the two. That's called an ambicohort. An ambicohort means that I combine the two. I use retrospective data, take the same people, presumably that they're still working at the plant, and then continue it into the future. So it combines retrospective and prospective into the same study. This is kind of a qualitative example. It comes from Kelsey et al. That I told you about, one of the references I gave you at the beginning. This is kind of a prospective. This is autoimmune. Rheumatoid arthritis is an autoimmune condition. 10,000 people. They took blood samples, tested them for the presence of the RA antigen, the rheumatoid arthritis antigen, and then they assessed exposure or non-exposure to that antigen, because the antigen was considered the exposure. There was some idea that this might be genetic, have a genetic component to it. And then, after 10 years, they they came back and they tested those people to see whether or not they had rheumatoid arthritis. That is, like I said, that's a somewhat rare condition. It's getting less rare now, but that was 10 years. They required a 10 years latency in order to determine whether or not the rheumatoid, they felt they needed the depth of at least 10 years to determine whether or not rheumatoid arthritis was developed. Okay? Because most of the time people develop that probably into their 40s or later. Okay. All right, why don't you guys take about 15 minutes, and then I'll continue with this topic.